Good morning, everyone, and thank you for joining us for the 5x5 Antimicrobial Audit webinar on intervention and feedback. My name is Yvette Warner, and in the room with me is my colleague Kate Callaghan, and we'll be taking you through this morning's presentation. Just a reminder that we're recording the webinar, and so in order to facilitate that recording, we'll be putting you on mute as we work through the slides, but we'll be stopping at various points throughout the presentation for some discussion and questions. So I'll just put you on mute now.
The host has placed the conference on mute.
Okay, so just to recap in case you weren't at session 1 or session 2 of the webinar, the 5x5 Antimicrobial Audit is a continuous audit intervention and feedback activity based on quality improvement principles. It captures data on 2 key antimicrobial prescribing indicators, and they are the documented indication for antimicrobial therapy and the choice of antimicrobial therapy being consistent with guidelines or inconsistent but with a documented reason. Auditors are prompted to make interventions at the point of care to promote best practice prescribing, and this is essentially when either of those 2 indicators have not been met. It's called the 5x5 Antimicrobial Audit because it requires the collection of data on 5 questions for 5 patients per week in a particular unit or within a service or in a small facility. Results are intended to be fed back to prescribers and other people in your facility or your unit or the ward that are affected by the audit on a regular basis. And we know from pilot testing that it's a sustainable and flexible activity. It can usually be incorporated into a clinical healthcare professional's regular duties, taking about an hour a week to identify 5 patients that are eligible for audit, answer the 5 questions, make any necessary interventions, and document the results. So that's just a recap. Today is the last of our 3 sessions on the 5x5 Antimicrobial Audit, and what we'll be talking about today is when an intervention is needed for the 5x5 Antimicrobial Audit and how to initiate it. Then Kate will be speaking to you all about giving feedback of 5x5 Antimicrobial Audit results, and then some final tips on getting started. We hope by then you'll be very inspired to start the audit in your facilities. Okay, so if you're familiar, if you recall from the previous session, questions 2 and questions 5 in the audit prompt an intervention with the prescriber. So an intervention is needed when an indication for antimicrobial therapy has not been clearly documented in the patient's progress notes, on their medication chart, or in their electronic medical record. And in these circumstances, auditors are prompted to clarify the indication for antimicrobial therapy. Once they do this, this allows the auditor to go on to question 3 and look at whether the choice of antimicrobial therapy is concordant with guidelines. And if the choice is not concordant with guidelines and the prescriber has not documented a reason for diverting from the guidelines, then auditors are prompted to recommend guideline concordant antimicrobial therapy. So they're the 2 key interventions for this audit. When we say contact the doctor or medical team, auditors should approach the doctor or medical team that's currently responsible for the patient, that's looking after the patient that's in front of you that you're auditing. So this may or may not be the person who prescribed the antimicrobial on the chart originally. In terms of how to initiate an intervention, we would always recommend verbal communication as the first point of contact. This allows 2-way discussion, and if you need to clarify the indication for antimicrobial therapy, it gives you the answer and then you're able to go on and continue with the audit. We'd always recommend, as with any intervention or any interaction you have with prescribers or with people looking after your patients in the hospital, people involved in their care, that you introduce yourself and provide some relevant patient details. So in the context of the audit interventions, it would be the patient's name, the ward or the unit or location that the patient's in, and what antimicrobial therapy they're on. It's a good idea to briefly state your reason for initiating contact when you first make contact, and to ask open-ended questions. So rather than ask questions that end with a yes or a no, ask open-ended questions and listen to the responses and be prepared for how you might deal with those responses. In terms of tips, be prepared. So if you are asking for clarification of the indication, look up what you think the recommended therapy is for the most likely indications that that patient's going to have. So say, for example, they had a chest infection and you were contacting the prescriber just to find out a bit more specifically what that chest infection was. You might want to look up recommendations for community-acquired pneumonia, for infective exacerbations of COPD, or similar lower respiratory tract infections. Be open to reasons for non-concordance. So this audit is not about right or wrong. It's essentially about having a discussion with prescribers on guideline concordant therapy. And by finding out some of the reasons for non-concordance, this might help you to better understand beliefs and attitudes towards guidelines that can then be targets for improvement and address any myths that the prescriber might have on the effectiveness of certain antimicrobials or the safety profile of certain antimicrobials. It's always a good idea to conclude your intervention with an action. So this might be changing antimicrobial therapy in that particular patient that you're auditing, or it might be a general recommendation for the future. So say if you're making an intervention about documenting the indication for therapy, you might want to conclude your discussion with saying to the prescriber, in future would you be able to document the indication for antimicrobial therapy in the notes so that everyone on the team understands what the patient is on that antimicrobial for. Okay, so Kate and I are now going to do a series of role plays. When we do the 5x5 Antimicrobial Audit training as a face-to-face session, you as the potential auditors would be doing the role plays, but we'll do them here in the CEC office, and then we'll talk about perhaps what went well and what didn't with those role plays. We realise that these kind of interventions are core business to some of you that are on the other end of the phone line, but to others it may be new. And if it is something that you regularly do, just keep the techniques in mind when you're training other auditors that may not be as familiar or as comfortable with making interventions. Okay, so our first case is Mrs. Beryl White, and she was admitted to hospital yesterday. She's on empiric antibiotics and is eligible for the 5x5 antimicrobial audit. She's on piperacillin and tazobactam, which is tazocin, 4.5 grams intravenously every 8 hours, and gentamicin 180 milligrams intravenously once daily. The indication box on her medication chart is blank, and you refer to her notes and see she came in with fevers and rigor. She's been feeling unwell for the last 5 days, and her medical history has been documented along with her OBS, and you know that she's got multiple comorbidities, including diabetes and COPD. When you go to question 1 for the audit and you look for an indication for antimicrobial therapy, you just see that the impression on admission was that the patient has query sepsis or a UTI, urinary tract infection, or a chest infection. And the plan that's documented in the patient's file is to start IV antibiotics and fluids and undertake some investigation. So you go in to look at what Concordance's guidelines is for these indications, and you see that there's 4 possible things that it might be. So it could be severe sepsis with no obvious source, severe sepsis with the urinary tract source, severe community-acquired pneumonia, which is the same therapy as severe sepsis with a pneumonia source, and severe sepsis for febrile neutropenic patients. And the doctor looking after Mrs. White today has just stepped onto the ward. So in this role play, I'll be the nurse looking after Mrs. White, and I'll be the auditor, and Kate will be Doctor who will be the doctor that's looking after Mrs. White. Okay, so here's our role play, take 1. Hi Doctor Who, I'm just doing the audit to Mrs. White. You haven't documented the indication clearly, so I just want to find out why.
Wait, who are you? What audit are you talking about?
Okay, sorry, Sibeth here. I'm the nurse looking after Mrs. White on this ward. I'm doing the 5x5 antimicrobial audit.
Okay, well, I don't know what the 5x5 Antimicrobial Audit is, and I really wish you wouldn't bother me about your audit issues. Is there something else I need to know about Mrs. White or not?
No, nothing. Sorry to bother you. I'll get the num to give you some information about the audit. Look, I'll just answer no and get back to it. Okay, end of role play. So let's try that one again. This time with the auditor keeping in mind some of those tips about giving a bit of a better introduction, and we'll see if that results in a different outcome. So this is our role play take 2. Hi Dr. Hu, good to see you today. I'm Yvette, the nurse looking after Mrs. White on this ward. Do you have a moment to talk about her antibiotic therapy?
Yeah, look, I'm quite busy, but what's the issue?
Well, I noticed she was started on tazocin and gentamicin when she came in yesterday, and at the time it seemed like the team were a bit unsure as to what infection she might have. Her notes say it might have been sepsis or a urinary tract infection or a chest infection. Do you have a better understanding now of what the tazocin and gentamicin are for?
Yeah, look, I wasn't really sure of the source of the infection, but I know we used to give this combination all the time in oncology, and it worked a treat for anyone with a fever. Her medical history is a bit vague, and I thought a urinary or a lung source was probably likely, given that's what's usually the cause of sepsis in our older patients.
So could I confirm what you're currently treating her for?
Well, based on how she's feeling today, and we've got a few of our tests back too, we think it's probably severe pyelonephritis.
Okay, thanks for confirming that. In that case, the guidelines we use recommend IV ampicillin and gentamicin until we have some microbiology results. Is there a special reason for prescribing tazocin?
Well, not really, just have it more than anything. I'm okay with ampicillin instead of tazocin if you think that's good enough.
It's what's recommended in the guidelines. Would you be able to document in her notes that you're treating severe pyelonephritis and maybe consider changing the tazocin?
Sure. Anything else?
No, thanks for your time. End of role play. Okay. Unmute you all.
The host has taken the conference off mute.
Okay, so time for a bit of a discussion. What do we think the auditor did differently second time round versus first time round, and how might that have influenced the outcome?
I think she introduced herself a little bit more professionally and a little bit more open as opposed to being too direct, and really just was more of an inquisitive nature about it, so it was a bit of like a softly approach, which worked well.
Yep. And so that inquisitive approach is something that we know in patient safety is a good way to sort of start these conversations, and just to sort of tell people, I suppose, we've noticed you've prescribed something differently to what's recommended. What are some of the reasons for this? Yep, so that's a really good point. Anything else that was different? Do you think it's good that the auditor didn't mention the audit second time round, or would you mention it if you were doing this?
They're not generally very popular, are they?
No, we're saying you're doing an audit can give that impression that, you're checking up on people or you're doing something quite bureaucratic. Whereas for the 5x5 Antimicrobial Audit, the kinds of questions we're asking are things that we think that, the medical team or the nursing staff or the pharmacist that's looking after the patient would want to know anyway as part of their routine care. So you don't need, if you think that the prescriber is familiar with the audit and knows why you're contacting them about it, then you can certainly mention it, but if not, you don't have to, because we do think that these things are questions that, it would be fair to ask those in routine situations. Any other comments? I think the other thing was the second time around the auditor acknowledged what had already been documented, and that the team were a bit unsure of the diagnosis, and we don't want auditors to make a judgment about that. It is quite reasonable on admission that there's a differential diagnosis, and that the prescriber may not have known exactly what they were treating, but I think acknowledging that you've read the notes and you've looked for an indication is also helpful because, otherwise the prescriber might think that you're wasting a little bit of their time. Okay, if there's no further comments, we'll go on to case 2. I'll just put you back on mute.
The host has placed the conference on mute.
Okay, so for case 2, this is a case of Mrs. Anna Garibaldi, and she's a 68-year-old female admitted to MAU for pneumonia by referral from her GP. The admission notes indicate that Mrs. Garibaldi has a fever of 38 degrees, sputum production and a cough. Her oxygen-ED showed a respiratory rate of 22, a heart rate of 85, blood pressure of 110 on 70, and oxygen saturations at 92% on room air. Her chest X-ray showed left lower lobe consolidation, and the impression on admission was she had CAP or community-acquired pneumonia. The documented plan was IV ceftriaxone and azithromycin. There's no microbiology results available, and you determine she's eligible for the 5x5. So you look at her medication chart, and she's on ceftriaxone 1 gram IV daily and azithromycin 500 milligrams IV daily, and you decide that that indication is clear enough to answer yes to question 1. You go on to question 3 and refer to your hospital guideline for CAP, which recommends use of the SMART COP or CORB score to determine severity, use of IV benzopenicillin and oral doxycycline for non-severe CAP for your inpatients initially, and use of IV ceftriaxone and azithromycin for severe CAP initially. So if this patient doesn't have severe CAP using the SMART COP or CORB criteria or any other red flags, and she doesn't have any known drug allergies, the prescriber hasn't stated their reason for selecting IV ceftriaxone and azithromycin instead of the recommended therapy of IV benzopenicillin and oral doxycycline. So you decide to ring the doctor this time to recommend guideline concordant therapy. So in this case, the auditor will take into account what we learned from the last scenario, giving an introduction and seeing how it goes. So in this role play, I'll be the ward pharmacist looking after the patient, and Kate will be Dr. G, who's attending to Mrs. Garibaldi. Okay, so here's our role play, take 1. Hi, Dr. G, it's Yvette, the pharmacist calling from the MAU. Do you have a moment to discuss Mrs. Anna Garibaldi, who's in bed 4?
Yes, what's the problem?
Well, I'm reviewing her medication chart, and I noticed she's on IV ceftriaxone and azithromycin for CAP. But since it's not severe CAP, you should prescribe that.
Why not? This is what I've always prescribed for pneumonia. No one's ever told me anything different.
Well, you're not following the guidelines.
What guidelines? Besides, I've had years of experience. I know that ceftriaxone and azithromycin work for these patients. You can't tell me what to prescribe. What's this about anyway? Don't you have discharge to dispense?
Yeah, I've got a lot to do actually. Anyway, this is just for some CEC audit, and I can now tick it off. Bye. Okay, this is the end of our role play. So let's try again. This time with the auditor taking a slightly different approach, still giving that introduction, but just handling the situation a little bit differently. Okay, take 2. Ring. Hi, Dr. G. It's Yvette, the pharmacist calling from the MAU. Do you have a moment to discuss Mrs. Anna Garibaldi, who's in bed 4?
Yes, what's the problem?
Well, I'm reviewing her medication chart, and I noticed she's on IV ceftriaxone and azithromycin for CAP. I've calculated her pneumonia severity using the CORB score, and she doesn't seem to have severe CAP based on her odds. She also isn't allergic to any antibiotics.
Okay, so what are you getting at?
Well, for non-severe CAP, our guidelines recommend IV benzopenicillin and oral doxycycline. Is there a special reason why you have her on ceftriaxone and azithromycin?
To be honest, I thought the standard antibiotics used here for pneumonia were ceftriaxone and azithromycin. No one's ever told me anything different. I'm pretty sure it's what the consultant wants to do. The patient is getting better, so I don't really understand why this is an issue.
Well, we're doing an antimicrobial stewardship audit at the moment, comparing the antibiotics that are being prescribed on this ward to what's in the guidelines, and my role is to speak to doctors if they don't match up.
Oh, okay. Sounds interesting. Do the consultants know about this?
They should. The DMS emailed them about it, but I'm more than happy to send you some information if you want. I'll also be presenting the audit results at the monthly M&M meeting on this board for discussion.
Okay. Wait, so guidelines don't really apply to everyone though. So Mrs. Garibaldi, for example, she's lying down a lot, and with her history of reflux esophagitis, I don't really think giving a doxycycline's a great idea.
You didn't know about the reflux. Erythromycin may be a better choice in that case. Look, we recognise that there may be special reasons why the antibiotics recommended in the guidelines don't suit everyone. And just so you know, if you document the reason why you've diverted from guidelines, this gets recorded in the audit, and I won't need to contact you about changing therapy.
Right, well, sounds fair. I'll have a chat with the consultants about it and see what they think. At this stage, I really don't think it's worth changing Mrs. Garibaldi's antibiotics today. She's doing pretty well, and she might actually be ready for orals tomorrow. But I'll keep what you said in mind. See you tomorrow.
The host has taken the conference off mute.
So that was the end of our role play for case 2. So what do you think the auditor did differently second time round that might have led to more of a productive discussion about the therapy? Is that an approach that some of you would use, the second approach?
So it's a lot more productive. Obviously, once again, it's about the manner and not being objective or, being kind of like, supervising the prescriber. It's more about having the discussion, which is more fruitful. So, it's a much better approach.
Yeah, and if an audit like this or interventions like this are really new to some of your prescribers, you might get that reaction that reaction is, I've always prescribed this, for pneumonia, no one's ever told me not to, what's this all about? So in those situations, it can be helpful to bring up the audit, or say something, about your antimicrobial stewardship program generally, that, that this is something that we're now putting a lot of effort into promoting, and these are the reasons and so forth. So definitely that's a good point. And the auditor also, the second time round, was a bit less judgmental about what was being prescribed. And so as we mentioned earlier with the tips, this isn't about right or wrong, it's about having that discussion. Anything else? So the other thing we think is that the doctor might be a bit defensive about being contacted. So the first time around, I think the doctor tried to sort of deflect the discussion by saying, don't you have discharge prescriptions to do? And that might come across rude, and look, it might be that the prescriber wants to talk to you about another patient, sort of deflect the discussion about that antimicrobial therapy. And so what we're just trying to achieve with these role plays is get you to think about what reactions you might get when you make these interventions, and how you can turn some of those reactions around and turn it into a more productive discussion. The first time around, the auditor also said, this is just some CEC thing and I can now pick it off. And I'm sure while some of you might feel that way when you're conducting the audit, it doesn't really help with changing that prescribing culture on the ward. It's about, changing therapy to be more concordant with guidelines so that patients are on more appropriate therapy. Okay, we'll move on to case 3, and because you're all very quiet this morning, I don't think I have to put the phone line on mute, which is good. Okay, so for case 3, this is Mr. Andrew Crispin, and he's a 78-year-old frail elderly man admitted with right upper quadrant pain, anorexia, nausea and vomiting, fever and jaundice. You're in the emergency department, and you notice that he's been commenced on ampicillin 1 gram IV every 6 hours and metronidazole 500 milligrams IV twice a day. Blood test and an ultrasound have been ordered, but no microbiology tests are available, and you determine that he's eligible for the 5x5. you go to do question 1 and you look for an indication for therapy, and you find a worsening diagnosis of acute cholecystitis through biliary obstruction in the patient's electronic medical record, and along with his medical history and his medication list. So you go to question 3 and look up your hospital prescribing guidelines, and the following antibiotics are recommended. Ampicillin 2 grams IV every 6 hours, plus gentamicin 4 to 5 milligrams per kilogram IV stat, then reviewing according to renal function, plus metronidazole 500 milligrams IV twice a day or 400 milligrams orally. You can't find a reason documented in the notes for the omission of gentamicin, so you contact the doctor. And in this particular role play, I'll be the auditor, and I'll be someone with a bit more knowledge of antibiotics as a doctor working with infectious diseases. Hopefully in this role play we'll just do one take. Hopefully it will be an okay take, and it will highlight how an intervention can be used as a teaching opportunity. Okay, so here we go. Hi Sarah, are you the doctor looking after Mr. Andrew Crispin at the moment?
Yeah, I'm looking after him while he's here in ED. He'll probably need to be admitted though. We're getting on at the surgical team to have a look at him.
Great, thanks for confirming that. I'm Yvette, I'm an RMO working with the infectious diseases team on an antimicrobial stewardship round. We're looking at patients in ED that have been started on antibiotics, and I noticed Mr. Crispin's on ampicillin and metronidazole for acute cholecystitis.
Yeah, cholecystitis is what we're thinking. Possibly biliary destruction as well. We're waiting on blood results now.
Okay, well one of the things we're trying to promote on our rounds is use of our hospital antimicrobial prescribing guidelines.
Okay. Wow, I didn't even know we had any. I just use TG or prescribe whatever the admitting team are asking for.
Oh, that's understandable. Our guidelines are actually very similar to TG, with some changes made based on our local antimicrobial resistance patterns. For acute cholecystitis, our guidelines recommend IV ampicillin and gentamicin initially, with metronidazole if you think there's biliary obstruction or an anaerobic infection. Is there any particular reason why Mr. Crispin isn't on gentamicin?
Yeah, I did think about it. He's pretty frail. Due to his age, I was actually really reluctant to give him any Genta. Once I've had a chance to look at his blood, which should come back pretty soon, I'll know what his renal function is like and I'll decide then.
Sounds like a good plan. Could you make a note about that in his file investment? It just helps to keep everyone on the same page about his antibiotic plan. If gentamicin isn't suitable, I'd recommend using either ceftriaxone or piptaz. If you use ceftriaxone, you could ditch the ampicillin, and if you use piptaz, this does anaerobic cover, and you could stop both the ampicillin and the metronidazole.
Okay, cool. Would I need approval for either of those?
Yeah, they're restricted because for the majority of our patients, IV gentamicin and ampicillin would be the way to go. Just mention his age and his frailty when you make the request.
Okay, great. Thanks for the advice.
End of role play. Okay, so hopefully that highlights how you can, if you have more knowledge of antibiotics or you're in a role where you can sort of expand your explanation about why guideline concordant therapy is recommended, then we would encourage you to do so within the scope of your usual role in the hospital. And we recommend that you practice interventions with colleagues using those likely reactions that you'll get from prescribers in your facility. It'll just make everyone a bit more confident and a bit more comfortable with making the interventions. Any comments on case 3 or that last role play?
That sounds straightforward.
Yep. Good. Okay, well, if there's no further comments, I'll hand over to Kate, who will talk about feedback of audit results.
Hi everyone. So as Yvette said, I'm going to be talking about feedback, which is a very important part of the 5x5 Antimicrobial Audit method. And basically that method draws on 2 different mechanisms to promote practice change. So the first one is that point of care intervention, which we've now covered in quite a bit of detail, and the other one is regular and targeted feedback of your audit results. So we actually recommend that as part of an audit coordinator's role to develop a clear plan for delivering feedback to the right people. And it's a really good idea to lay that groundwork and have those lines of feedback prepped and ready to go prior to actually launching the audit. That feedback should be targeted to both prescribers and other stakeholders, and you'll probably need to use a combination of different methods to get those messages out. Feedback to your prescribers should be very targeted and should be targeted as much as possible to those prescriber groups who are most responsible for the results that you're actually reporting. Other stakeholders who might be invested in or interested in the results of the audit are people like nursing and pharmacy managers, quality managers, directors of clinical services or clinical governance, and obviously any relevant committees such as Antimicrobial Stewardship Committee, perhaps the Medication Safety Committee or the Drug and Therapeutics Committee. It's also very important to make sure that your auditors are aware of and are included in those feedback loops, because it helps them to see that something's actually happening with all the data that they've been collecting, and hopefully that data will be showing some trends towards improvement, which is, is a form of encouragement. It encourages them to keep going with their audit process. On this slide, we've got some evidence-based guidance around what factors make feedback actually more effective in generating or contributing to change in prescriber behaviours. There are a number of really excellent articles out there in the literature. Some of them we've actually listed as references in our audit user guide, and they include a Cochrane review, which actually summarises some of the key points that we've got listed here. So we know from that literature that feedback is most effective when it's provided by a respected peer or a supervisor. And I think it's important to emphasise here that this person who's delivering that feedback should either already be respected by the feedback recipient or at least have the capacity to earn their respect as a result of those interactions. The feedback should be provided on more than one occasion in both written and verbal formats. It should include a specific target and an action plan. So, for example, we often recommend a target of at least 95% for both of our 5x5 indicators. And when the results are falling short of that target, you'd be expected to provide some advice with regards to how further improvements could actually be made. Feedback should be provided in a timely manner. So we are all aware of examples of audits where, it takes a couple of months for the data to be processed properly, and then in a couple of months further down the track, someone finally releases a report or perhaps gives a grand round presentation about it. But by that time, the value and impact of that data has actually diminished quite a lot. So we would tend to recommend that feedback of your audit results should be occurring at least monthly. As the longer you leave it, the less relevant that feedback will seem when you finally get around to providing it. And lastly, feedback should be individualised but non-punitive in nature. So individualised is referring to actually targeting that feedback to the right groups of people, and non-punitive just means that it's without any expectation of punishment or a reprimand for poor performance. Okay, so we'd like to emphasise when you're coordinating your feedback plan, you should prepare to use a combination of both active and passive feedback methods. So some examples of active feedback might be actually presenting the latest audit results at fortnightly or monthly clinician meetings and at relevant committee meetings. Incorporating your audit results and feedback into any relevant education sessions. So perhaps the results or some of your key cases that, from your audit data that you've collected could be referred to during something like JMO education or perhaps grand round presentations. You can provide opportunistic in-person updates and encouragement. So this might mean actually mentioning the latest results in your conversations with people on the wards, or actually just taking the time to congratulate prescribing teams if they've been doing particularly well. And another example is actually asking for return feedback and some input from those who are receiving your feedback in the first place. So for example, perhaps after talking about the latest results at a clinicians meeting, you might then ask them if anyone has any suggestions for how guideline-based prescribing could be better supported, and consider acting on any of their suggestions that they offer you. And some examples of more passive feedback might be sending out copies of monthly reports of your audit data via email or perhaps in hard copy. And that's something that is very, very easy to do in addition to your more active feedback strategies. But on its own, without the active feedback, it's really not likely to have much of a major impact. You can update run charts of your indicator results, which you can post in staff areas and on bulletin boards. Or perhaps just being ready and willing to discuss the results when asked or when it happens to come up in conversation. Okay, so on this slide we've just got a few pieces of advice to keep in mind regarding your feedback techniques. So the first one is that if you're speaking to a group of people in a meeting situation, try to organise it so that you're actually going to be introduced properly, and ideally that introduction is going to come from a supportive chairperson at that meeting. So being introduced well can have a really big impact on how your feedback's received, because if the chairperson is demonstrating that they are engaged with and interested in what you have to say, then that sets up everyone else in the room to be more invested in what you've got to say as well. Think about the types of questions that prescribers might ask and what your responses should be. So, for example, if you know that some people might be questioning the limitations of the audit methodology, then be prepared to have that discussion. Or perhaps if a prescriber group is likely to want to know more details about the type of cases that they were missing, where they were missing indicators, it's probably a good idea to have that information ready to go. Combine your feedback with small but direct education sessions. So, for example, if you find that half of all the cases of guideline non-concordance on the ward that you're auditing were cases of UTIs, you could perhaps combine that feedback with a quick tutorial about the latest evidence for managing UTIs in that particular patient population. The next point there is that if variation in practice is high, try to generate discussion which opens up your prescribers to peer influence. Now what we mean by that is that out of all the various influences and factors that contribute to a doctor's prescribing choices, their peers, so the actual colleagues that they're working with day to day, are often one of the biggest influences when it comes to changing their practice. So if you're finding a lot of variation in what's being prescribed by different teams for the same types of conditions, you can actually highlight that variation and perhaps use it to prompt some discussion amongst your doctors. And hopefully that discussion will actually lean towards favouring those doctors whose practice is most closely aligned with the guideline recommendations. Always make sure that feedback is offered as a two-way street, and as I said before, try to be solution-oriented regarding the issues that they might raise. And lastly, accept that you may encounter some prescribers whose practice is just simply never going to change, and you're going to have to just accept that, take it on the chin, and instead focus on the ones that you can change. Okay, so now I'm just going to briefly run through what's mostly listed on the Audit Coordinator checklist, which can actually be found in Appendix D of the Audit User Guide. So this is a good frame of reference for people to have a look at as a summary of the steps that should be taken in preparing to launch the 5x5 Antimicrobial Audit. So in terms of basic decisions that you have to make up front, you'll need to select an appropriate audit population, remembering that your data collection should be as focused as possible, so usually on a specific location or specialty within your hospital, depending on your hospital size, but while still trying to maximise the likelihood of producing 20 solid audit records. You'll need to select suitable personnel as your auditors, and ideally we would recommend doctors, pharmacists or registered nurses who have an interest in antimicrobial stewardship. And an audit launch date has to be chosen. So that's the date that you're actually going to start, you're actually going to commence your data collection. Then under the communication and engagement section of the checklist, we would expect that target prescriber groups will have been engaged, again, prior to that audit launch date. So all prescribers whose patients may be audited should be aware of the audit and have opportunities to ask questions or voice their concerns. We also expect you to have engaged your other relevant stakeholders across the hospital and to have considered other channels of communication. So you might want to, for example, put some posters up on the ward or perhaps put some information in something like a local staff newsletter. In terms of auditor preparation, all of your auditors will need to have been provided with a copy of the relevant documents. So that includes the Audit User Guide, frequently asked questions, the CAP cheat sheet, and a few other things that might be of use to them in the audit package. The auditors need to have received appropriate training for their role, so actually taking them through the same sorts of principles that we've covered in our training webinars, and also perhaps doing some practice auditing on site, because when you actually do the practice auditing, you realise that it's not quite as simple as it sounds when you're just looking at it on paper. The auditors do need to be made aware of the data collection quotas that they're aiming for, and give them a pathway of what they should do or who they should speak to if those quotas aren't going to be met during a particular week or month. Under the data analysis and feedback section, you should be selecting your key analysis parameters. So in the first webinar, I actually gave a quick demo of the spreadsheet that we use to collate and analyse our data, and you might remember that there were up to 3 parameters by which you could stratify your data if you had that information collected. So it might be by hospital, ward and specialty, or it might be by ward, specialty and team. So you pick those parameters up front depending on your needs. Before you start collecting data, you should definitely already have plans in place regarding who's going to collate and review that data, and how often they're going to be doing that. You should also have some plans in place for delivering your regular feedback to prescribers and other stakeholders. And the last point there is that for every responsibility that you're assigning, you need to have some contingency plans in place already, because people are always going on leave or unable to fill their role for whatever reason, and you're going to need some plans in place that you can fall back on in those instances. And for our final slide, we thought we'd actually take you through what we call some key determinants of success that we identified from the 12-month pilot project of the 5x5 Antimicrobial Audit. So it's a really good idea to keep these points in mind in order to boost your own chances of successfully implementing the audit and actually generating some sustainable practice change. So during the pilot, we observed that pilot sites were more likely to show improvement if the audit population had relatively low baseline results, so they actually had room to improve in the first place. Prescribers were positively engaged with the audit, so not all of your prescribers might be jumping up and down, they might not be super enthusiastic, but at least if you have a prescriber group that's at least on board with the idea of the audit and receiving that regular feedback, then that's certainly a positive marker. The feedback could be easily targeted to prescriber groups. So, for example, if you're auditing in an area that has a really wide range of teams coming through, so something like a medical assessment unit, for example, it can be really hard to target that feedback. So you need to have some strong plans and suitable strategies in place to ensure that the feedback is going to the right people. They were more likely to show improvement if feedback to prescribers was delivered regularly and in at least one forum which allows for discussion of those results. So we've always said that one of the most powerful things about this whole audit and feedback methodology is the conversations that it starts. So you do need to make sure that you're regularly feeding back and it is in a forum that allows for that discussion and those conversations to actually happen. There were high rates of follow-through when making an intervention when prompted. So we do give auditors that option to say yes or no as to whether or not they did make the intervention when it's prompted by the audit tool. But we'd like to think that they are making those interventions far more often than they're choosing not to. And data collection consistently met the quota of greater than or equal to 20 patients per month if you're able to get 20 eligible patients per month. So that sample size was actually very decent and therefore you weren't missing a lot of patients in your audit process. So that's just our general summary, our last tips for success. We might move on to see if anyone's got any questions. Does anyone have any questions about what Kate covered or anything we've covered across the 3 webinars?
That sounds good, thank you.
Excellent. Good.
Hello?
Yes?
Can I just ask, in our facility, we're very small, we're not going to get to 20 a month. So how does that work? Like, at the moment we've got 7 patients, so...
Look, it is a question that we commonly get because this is probably Out of the various audit tools out there for antimicrobials, this is one that can be adapted to very small facilities, and you don't need that expertise. But when it comes to the sample size, you're not going to get 20 patients a month, and we recognise that. So the advice that we tend to provide is if you're actually, it can be advantageous in a sense that if you have a system in place where all of your patients who are eligible, say it's only 8 a month or something like that, if you're capturing all of them, then you actually get to say as part of your feedback that this isn't a representative sample. This is the true population. This is definitely how we are managing our patients who are receiving acute antimicrobial therapy that's prescribed empirically. So it can be done, and it is still important to provide that feedback. It's just that you probably won't be doing it as rigorously. And don't sweat if you're not getting the 20 patients a month. Just try and get all of your patients who do happen to be eligible for the audit.
The other thing you can do is if in your area there's a lot of small facilities and there's some overlap between the prescribers, you can pull your data with other small facilities in your area and then share the results with the prescribers that are involved in that area. Although generally the more specific the feedback, as in the more likely it is that you're giving the prescriber the results of their actual prescribing, the more powerful those results are going to be.
But it can be, that's right when it comes to pulling that data. So say you're in a local health district with a lot of small facilities, perhaps a lot of MPSs that choose to use this audit. If it's being coordinated at that higher level, perhaps across a network of facilities, then pulling that data can actually be useful from a strategic sense. So someone might analyse that data and see that, our MPSs are performing this well compared to some of our larger or more central facilities. Therefore, maybe we need to provide them with a bit more targeted education or, something like that. So you can actually uncover some really useful information for antimicrobial stewardship programs generally.
Okay, thank you.
Any other questions? Comments? Okay, if there's no further questions but you think of some after we hang up, you can contact us at the CEC by email. So our email address is cec-hai@health.newsouthwales.gov.au, or you can give the CEC reception a call on 0292695500, and depending on whether Kate or I in the office, they'll put you through to one of us. Thank you everyone for your participation in today's webinar and in the series of webinars. We hope you found it helpful. We hope that this is something that you'll be able to use in your facility. And as I mentioned at the start, we'll be putting the webinar recordings on our website, so if any of your colleagues were unable to join in today and